Hello, I'm Dr. Youngjae Kim, President of Korea Dental Hospital. Today, I would like to give you an opportunity to learn more about the SLOCK implant, from implant surgery and prosthetics to full mouth rehabilitation and removable prosthesis. I've been developing the SLOCK implant for about 15 years now, and I have about 15 years of actual clinical results. And then I updated it, and now I'm doing implants with two different systems, the locking system and the Torx++ system. Actually, regardless of the type of implant, you need some knowledge to do implants. So I'm going to talk about that knowledge. When we talk about knowledge, we have the English word knowledge, and then we have the word realize. We call it knowledge when we have more or less normal knowledge, and then we call it realize when we finally get to know it after trying this and that. So I'm going to talk about both of those things together, and that's what we're here for. So today's topic is titled Identification of Implant Treatment. But at the end of the day, it's really about how do we identify implant treatment so that we can have a successful implant. So I think it's appropriate to talk about that. I'm going to break it down into about 5 different themes, and I think the bottom line is that the implant fixture is placed in a good location, in a good orientation, and the prosthetic design, the occlusal design, determines the longevity of the implant. When you get an implant, the very first step is actually attaching the implant fixture to the bone, right? And then there's some process that maintains the implant. So the first title is osseointegration. We're talking about attaching the implant to the bone and maintaining it. And then the second one is, the implant is either a success or a failure, right, from our perspective. So we usually break it down into 4. One is success, and the second is survival. That means you survived. The third one is failing, where you're in the process of failing. And the fourth one is failed, where you've already failed. And then the question we have during this process is, what's the difference between an implant and a natural tooth? So we study the differences between a natural tooth and an implant in terms of the design of the occlusion or something like that. And then there's a condition called peri-implantitis, which is bone dissolution around the implant. And then you have to study how periodontitis and peri-implantitis are different, and they feed off each other. So these are things that are now being looked at as important. And then when you talk about these implants lasting longer, what do you mean the bone that surrounds the implant lasts longer? So there's a lot of misconceptions about that. So implant failure, number 1, is mechanical failure. What I mean by that is, if there's a mechanical failure, like a screw loosening, or the abutment breaks, or the fixture around the abutment breaks, and then beyond that, if the bone around the implant melts, the implant fails. Then, in a way, the occlusal load is transferred to the bone around the implant. So this bone can then be preserved, melted, or hardened. So that's what we're thinking about now. You want to have more bone so it lasts longer. So we're talking about this concept. And then finally, we're going to talk about how we're going to do the occlusion of the implant. And we're going to think, can we treat a longer lasting, functional and aesthetic implant? The first step is to realize that implant occlusion is not just about occlusion, as I mentioned earlier. It's also about aesthetics and function, because if the implant is in a good position or orientation, it's aesthetic and functional, right? Aesthetics and long-term results are good. On the other hand, if there's a problem with the positioning and orientation of the implant, then there's destruction. I'm thinking, isn't peri-implantitis a typical result of destruction? And I also think we need to be a bit more careful with implants. So, when you think about all of these positives and negatives, at the end of the day, the first step is to get the implant fixture in a good place, in a good orientation, and get it into the bone. Right? You have to attach the fixture to the bone, and that's the surgical phase, which takes about 3 to 6 months. Of course, if the bone quality is bad, you have to wait 9 months. I've had cases where I've waited a year. Even today, I have a case where I did bone grafts in the maxillary sinus and put in 2 implants, and I'm going to have to wait at least 6 months. I've even sent some patients to come back in a year or 2 if the bone hasn't healed that much. That's a long wait case. And then when it's implanted, it's usually 3 months, 6 months, the implant fixture is attached to the bone. And then there's the prosthetic phase. And that usually takes about a week to a month. But for a full mouth rehabilitation or something like that, it takes about a month. That's how long it takes to make the prosthesis. I've had cases where it's taken almost a month or more to make the impression, then the abutment setting, then the temporization, then the final prosthesis. And then I'm explaining it like this. And then the last thing I'm explaining is, the implant is in and the prosthesis is done, but the actual bone attachment period is for the next month to a year. So the most critical time is usually between a day and a week. And if you overload it, the implant just falls out, which is what happened to me. I'm sure it's not for everybody, but if you don't have osseointegration, the fixture falls out while you're attaching the abutment. Even if you have a good abutment connection, if the bone doesn't hold up to the initial occlusal load, it will fall out in a week. I've seen a lot of cases like that. And then, if it's over a month, I'll call it a success. If it goes beyond a month, almost 99% of the time it's going to last 5 years, 10 years. So, how I usually explain it to patients is, you're going to continue to have osseointegration up to a year. So be careful not to chew too much hard food, not to create too much load, occlusal load, within a year. I mean, not everybody does that, but patients who have weak bones or patients who have had weak fixtures, they come in with fixtures coming out. But at least you have an excuse to talk about it, or at least give them a reason so they understand what's going on. But what if there's a problem? And then if the doctor can't explain it to the patient, then you have a bigger problem. I think you're going to end up with a lot of bad relationships with your patients. You have to be careful with that. So it's logical to say it should be an occlusion-oriented follow-up. So what's the most important thing to get osseointegration? It's bone quality and bone quantity. Sometimes there's not enough bone volume. Sometimes there's not enough bone quality. So that's the most important issue. Most of the surgeons don't get out of that within the first 10 years of practice. So you learn about bone grafting, you learn about GBR, guided bone regeneration, you learn about socket preservation, you learn about all this stuff. But my experience has been a little bit on the negative side. I didn't have a lot of cases where I did bone graft and it didn't work out. Logically, when you do a bone graft, you put the graft bone on some defect area. And then what happens to it to become bone? The graft bone must be absorbed, and the new bone from your own body must fill the graft area for the bone graft to be successful. But most of the time, it's now called non-functional bone, and in my case, it had a cement-like feel to it, so when I put function on it, the graft bone just dissolved. So a lot of people write GBR books and talk about different things, but the outcome is not good. What is the typical system of implants that have survived recently? Almost all of the implants that have lasted are the ones that are only placed where there is bone. There are a lot of implants that did GBR or bone graft when there was no bone that didn't last long. So I think we have to be careful because there is some skepticism about GBR or bone graft now. So I think the most important thing is to have adequate bone mass and bone quality and to do a delicate surgery. And then the second thing is that it's all about maintenance. So once it's osseointegrated, it's all about how are we going to maintain this? And most of the time, what we're talking about is occlusion and accurate prosthesis. Actually, I say occlusion is important, but most people don't understand that. So I've been working hard on my occlusion lectures, and some of you have gotten it, some of you still don't get it, but most of you know this. If you overload more than the neighboring teeth, you're in trouble. If you know that much, you know a lot. And I would like you to understand a little bit more about biomechanics. But at the end of the day, I think it's the correct prosthetic restoration, proper functional load design, and then good oral hygiene that will maintain osseointegration. So let's just look at the surgical phase a little bit more. Because there's a prosthetic phase, there's a maintenance phase, there's all these things, but if you're doing implants, you're focusing on the surgical phase. I'm the opposite. I'm approaching that implant surgery from the maintenance phase side, and we call it a prosthetic-oriented implant. I would describe it in some ways as occlusion-oriented implant surgery, personally. So let's take that and go a little bit further. So now, if you have bone deficiency, you do GBR, you do bone augmentation, you do sinus elevation, you do socket lift, you do ridge split, you do mandibular nerve repositioning, and then you do distractive osteogenesis. Some people call it osteogenesis, some people call it synthesis. There's a lot of different things, but GBR is the most common. It has a high success rate. And then bone augmentation, I think we used to do a lot of block bone and stuff like that. I don't do a lot of that now. And then there's now sinus elevation, so there's a lateral approach to put the graft in. And then there's a crestal approach under the sinus, which is called a socket lift. I do this a lot. I also do sinus elevation. And I think in cases where the socket lift fails, where you need this extensive maxillary sinus bone graft, I think sinus elevation is advantageous. But I still do a lot of socket lifts. And then ridge splits, I used to do them, but I don't do them as much now. Because it's troublesome if the bone breaks. I'm only doing a little bit of it on the maxillary anterior incisors. I'm now doing it with bone extension, and I'm doing it in the direction of extension and split. Mandibular nerve repositioning is something that you do a lot when you don't have enough mandibular bone mass. But after doing a few of those, I stopped doing them. Almost 100% of the time, the nerve injury gets worse, and then I realized that it's better to just recognize the nerve injury and plant it. And I think that's what I did. So I planted it, and it's still going strong, almost 30 years later. It's a long one, sure. So I think that has its advantages. It's called DU. I've done a few cases of distractive osteogenesis, but I don't do it anymore because it's too traumatic. If the bone quality is not good, I mostly use the bone compaction technique a lot. I do that almost every day, and then I'll use bioactive or rough surface on the fixture. So the SLOCK implant right now is a nanosurface. This one has a nano SLA structure. So it seems to be sticking a little bit better. It's sticking like crazy. And then the third thing is to increase the initial fixation. So that's something that we've been struggling with a lot. So I think the reason why the SLOCK implant is working so well now is because of the second and third reason. The fixture threads are very active. The cutting groove on the inferior side of the fixture is called a spiral cut. That side cut that comes up from the bottom, it's designed to be very active. So I'm thinking, well, that's probably a big help. And then for me, I'd probably use a fixture that's as long or as large in diameter as possible. That's the most important thing. If you don't have that, it's almost impossible to get a proper initial fixation with poor bone quality. So, especially in the anterior region, you want to plant the fixture subcrestal. If you plant the fixture subcrestal, you're going into cancellous bone. It's not uncommon for the cancellous bone to be D3. It's more common than you think. There's a lot of D3 bone, so we actually have to place a wide fixture, like 4.7 millimeters in diameter, in the lateral incisors. If you don't put in something like that, you often don't get primary stabilization. And we try to use cortical bone anchorage whenever possible. The cancellous bone is weak, but in the case of the sinus floor or mandible, there's the mandibular lingual, the mylohyoid ridge of the superficial lingual, and then there's the cortical bone. And for anterior teeth, you've got the nasal rim, then the hard bones on the canine fossa. And then for maxillary first premolars, if you think about it, you have the maxillary sinus wall, the anterior wall, in the sinus cavity. So I use that, and then maxillary 7, I use a lot of cortical anchorage on the posterior wall in the maxillary sinus. Number 6 is the hard one. Maxillary 6 is hard because I use a lot of palatal anchorage. So that's a little bit difficult, but there's a lot of wide sinus. You have to think about that. So today, I planted an 8 millimeter diameter fixture in maxilla 6. I also wanted to put in a 9 millimeter fixture. There are quite a few cases like that lately, especially now we have a lot of Mongolian. So Korean people have a very developed maxillary sinus. So wide sinus cases are quite difficult if you don't use palatal bone anchorage. I think it would be helpful for you to study that kind of geometry, sinus geometry, and it would help you to place the implant. Mandibular advancement often requires the placement of dental implants. Placing an implant fixture in the maxillary anterior is not a big problem because there is a lot of labial and palatal cortical bone. If you have cancellous bone or poor bone quality, you're going to have to get that cortical bone anchorage that I was talking about anyway. I'm looking at it as getting the initial fixation that I can from that cortical bone. Now, after that, there's a lot of things that we're going to have to think about to maintain osseointegration. There's a lot of loading methods, things like progressive loading. So provisional restorations, we do pretty much all of them. We do pretty much everything except single implant restorations and things like that. But we do progressive loading for singles as well. And then we do a lot of delayed loading. Progressive loading, if you think about it, you're giving a certain amount of loading by the temporary restoration, and then you're loading harder and harder as the final restoration goes on. You're trying to get them to bite, and delayed loading is when you add 6 or 8 months to the time. For the patient who came in today, I told him to wait about 9 months. So I can't help it. The second thing is the loading conditions. So I think the fixture that I was talking about earlier, I think I used the longest or widest fixture possible. Large diameter ones, because those almost never fail. But recently, I've heard some brands say, you don't need to plant anything more than 4.7 millimeters in diameter and 8.5 millimeters long. I don't think that's true. I think that's not right. I've had too many failures, and they've all broken. They come in with broken fixtures, they come out, they have peri-implantitis, they have these problems, and I'm not sure why they're talking about that. I mean, a lot of my patients are really, really big people. I had a patient today who was from the provinces. He's an old man. He's in his 80s. and he's alone. When I asked him why he came, I didn't even ask him first. The patient says he's from somewhere. He's from out of town. And I said, "How did you get here?" And he said, "I have a friend who had dental implants done by you about 10 years ago. And his friend also said he hadn't been to the dentist since then, so he came." So the secret is, number one, we didn't reduce the number of fixtures. I think the moment you reduce the number of fixtures, you've already compromised the longevity, the outcome of the treatment, the long-term prognosis, and then we use the longest, thickest ones that we can, and then we plant them in a good location and a good orientation. So I think location and orientation is the most important thing. In my case, to give you an example, I had a patient once who said his brother is a dentist. "Why don't you go there?" And he said, "My brother is in the United States." So his brother said, "It doesn't matter what kind of implant he uses. It's important to find a surgeon who has a lot of experience, who can place the implant in a good position, in a good direction." That was his brother's advice. That's what his brother told him. So the first thing is location. You have to have a good location, and the second thing is you have to have a good orientation, because that's how you get the right emergence profile. If you think about it, we talk about aesthetic, we talk about porcelain, we talk about shade, we talk about this. But the emergence profile already determines that. So when I say aesthetic and functional implant, it's really just a prosthesis of an implant that's placed in a good position and in a good orientation. I don't know what you're thinking beyond that. But of course, shade and shape are important. But if you don't have the basics of prosthesis and fixture placement, you can't do anything else. If you look at the implants that are failing now, they're implants that have a lot of cantilevering because of poor positioning. These things tend to fall out. And nowadays, the fixtures that are just made to make it easier to implant, those are the ones that don't have good loading condition results. So I try to use as long and wide as possible, but the ones that are just for implantation, the ones that are just threaded, the ones that are just pointed are not good for longevity. It's not going to hold up from a longevity standpoint. So I'm thinking maybe it's a good idea to think about this a little bit. At the end of the day, it's all about the crown-fixture ratio. If you run out of bone, you plant the fixture lower. That's going to lengthen the crown. So now if I don't use something that has a strong abutment connection, eventually the abutment will break, or the fixture will break in that area. It's going to come loose anyway, and then you have to put in something as long as possible so that the implant will last even if the crown-fixture ratio is unfavorable. And then it's the traditional story. No prematurity in centric occlusion and eccentric movement, and balanced occlusion, SITH, TMJ, and neuromuscular control. And then the host factor is important. I don't really know. But even in elderly patients, I don't think I've seen too many cases of osseointegration because of bad bone. Actually, downstairs in my hospital, I'm on the 4th floor, and I have an internal medicine department on the 2nd floor, and we have an internal medicine department that specializes in kidney dialysis. There's an internal medicine department that specializes in hemodialysis. So now they send a lot of extremely debilitated patients to us. But I haven't seen a case where the implant won't go in because the bone is bad. And I don't think diabetes or anything like that, I don't think I've ever really gotten the sense that implants don't stick, and I don't think osteoporosis patients don't stick either. But nowadays, osteoporosis patients take a lot of medication. So now it's scary. The situation now is it bisphosphonates when that osteonecrosis happens? I think the medications that people with osteoporosis take, it's like a mineral deposition in the cancellous bone. And what does that do? Well, it blocks the blood vessels. So the blood supply drops dramatically. So once you get an infection, you can't handle it anymore. So you get osteonecrosis. So you get osteomyelitis. So it's scary. So the host factor is important, and it doesn't matter if it's age or whatever. And they say it's because of hormones in women, but I don't think it is. From my experience, I don't think it's a big deal. Anyway, general health, gender, then age. After that, environmental factors are important, and the most important thing I consider is the patient's bite force. If you have a strong bite, you put a smaller fixture, right? Then you're going to have problems. So that's why it was very important. And then finally, the occlusal protocol is important for maintenance. So things like loading direction are important. And then you've got to plant it well, in a good location, in a good direction. And then now, axial loading is important, and it's important to eliminate a lot of horizontal stress. So I've been talking a lot about how we can reduce the occlusal surface with lingualized occlusion and buccalized occlusion. And then the occlusal concept. We end up saying centric relation is right, centric occlusion is right, but there's actually a functional position of that patient. And we'll talk about that a little bit more in the occlusal part. And then there's some people who argue for a mutually protected occlusion. How do people get canine implants? When they do canine implants, do they do canine guidance? Canine guidance, you can try it, right? What do you need then? You need a fixture that's as long and as thick as possible so that you can maintain the force of the canine, right? And then what's the point of having a thicker and longer fixture? Then you have to use a very strong abutment connection. But unfortunately, almost all of our domestic implants, so it's a constant problem. So in the end, the group function will last longer. If you think about it, it's a very obvious problem. Then the sequential guidance, which I've been arguing for, I think that's the right thing to do. Anyway, I've been talking about that, so I'll explain that later when we talk about occlusion. And then we have no prematurity, and then we have balanced occlusion, which I was talking about earlier, and then no periimplantitis, and then eventually osseointegration loss, which is something that we always have to watch out for. Anyway, so we've talked about a lot of these things, and now I'm going to talk a little bit more about fixture installation. I do a lot of socket lifts. This is a BioHorizon implant, which is an implant that I used to place back in the early days. It's claimed to be made by Carl Misch, but when I visited the actual BioHorizon headquarters, it was almost designed by someone from the material science at the University of Alabama rather than Carl Misch. And they borrowed Carl Misch's name and did most of the marketing, and the results in Korea were so bad that this implant was a total failure. It was so bad in Korea that all these implants were lost. And even if this is only attached to this end, this has no mobility. I think it's like that with Company O, and I think it's like that with almost all of the domestic implants. So what happens is, this is extensive horizontal bone loss. It's kind of a horrible situation, and I feel so bad for this patient. I tried so hard, and I'm sorry it turned out like this, but anyway, minus the extraction. And then, if you look at the sinus, there's some bone left because we did a bone graft through the sinus lateral window before. If you see here, this is where I use BioOSS, and there's quite a bit left. When you're planting, you're thinking, well, maybe if I use the palatal bone, the lateral side of the nasal cavity, I'm not going to get a good fixture fixation. I think we've lost the palatal bone here, and I'd like to use a little bit of the lateral side of the nasal cavity here as well. Some people have thought about doing GBR and doing vertical bone augmentation. But is that possible? You're better off not doing that. You shouldn't do that. So if you look at this situation, you've got fixtures all over the place. It's a terrible situation. That's why we're talking about longevity, because this is a case that's less than 10 years old. It's all melted down, and there's nothing we can do about it. We have a reamer that we use. We have a hatch reamer in our SLOCK implant surgical kit, and with the hatch reamer, we hit it a little bit like this, and then we raise it up like this, and then we raise the bone up here. So if you look, it went in like this. And if you push up without removing all of the bones here, you're going to have bones that are pushed up here, and the membrane is going to go up with it, and the initial fixation is going to come out of the nasal cavity lateral wall like this. So maxilla number 7 is simpler. We're using the lateral border of the nasal bone with the palatal bone, and we're using the lateral wall of the border. And if you see, this is blood-filled here, and I've taken a hatch reamer like this, and the bones have come up together like this. So if you do this, most of the time it's surprisingly easy. That's how I survived. So many cases come in, and if you can't do the maxillary sinus, you can't do as many implants. Most dental offices, as far as I know, don't do more than 50. I think most of the doctors that have more than 50 fixtures, they almost always solve the maxillary sinus problem in some way or another. So it's a very simple and straightforward procedure, and I think that's why I was most comfortable with it. I still do this almost every day. So I think it had its advantages, and if you observe, there's nothing special about it. The other side did the same thing. So if you look, I'm doing temporization like this. You can see that the bones are holding up well. That way, if you don't address the sinus with a socket lift, or a lateral approach, or a window technique where you're deficient, you're not going to increase the number of implants anyway. I mean, we're counting how many procedures we're doing a month. If that's not increasing, I think that's probably something that you need to think about. And then the DO, I went to Switzerland about 20 years ago, and what we do in oral surgery is we do DU in patients with maxillar deformities, and we used to do a lot of that in Switzerland. Professor Obergäser and others in Switzerland would do a green stick fracture in the maxilla and put a screw in and slowly pull it out. And then they'd say, well, why don't you just cut the maxilla and move it yourself? Because that doesn't allow bone growth. So they did quite a few of those things where you slowly pull it out and induce bone growth. And that's what they eventually brought to the implant side. So at one point, this was quite a big seller. Because we get a lot of difficult patients, and here's a patient who lost all of his anterior premaxilla because of trauma. So there are quite a few cases like this. So there's nothing you can do. Now, we used a DO machine from the Martin company. We didn't have cone beam CT, CBCT, at that time, so I think we used this medical CT. As you can see, the mandibular condyle here is also broken. I'm going to cut it and reattach it from the outside like this, and then I'm going to put it in like this. If you look at the one up here, there's also a condyle fracture. This is called Doctor Nam's technique, and it was used in Korea for a while. But later, it all dissolves. The condyle will dissolve, and probably this will dissolve the ramus as well. So they don't seem to do it anymore. Those are the methods that were used in Korea at one time. He doesn't have a premaxilla anyway, so it's kind of like this. So I explained to him, let's try distractive osteogenesis. So I said, let's try this. So I prepped it, and now I'm going to take a microsaw and cut it like this. And I think this is from Martin. It's a little old. I think they still have some in stock somewhere. But anyway, this was quite expensive. It was expensive, but anyway, you connect it like this, and then you suture it like this, and then you turn this, and it opens up here. It's gaping like this, and then now it's clicking. I forget now, but there's a protocol where there's a period of time where you turn it a quarter turn a day or something. But it's just slowly clicking, and I tried it. So I'd turn it every 3 days or so, and the gap would be like this. So that's why it's got this much bone. So I did this, and then this is the screwdriver. It's adding 0.5 millimeter per turn. I think you can turn it once a week. So I turned it like this. It's gone like this, a lot. So that's how it got this far apart. So I removed it, and then if you look at it now, what was a little bit of a weakness, the alveolar bone thickness, doesn't change. It doesn't increase. It just increases in length. That's all I could do then, and that's all I can do now. I've done quite a few. I think I've done a few. And anyway, I ended up doing bone expansion because I'm not getting any thickness here. So I took an expanding chisel like this, and I hit it like this, and I put in a fixture. And I didn't reduce the counts at that point. And this patient is not following up now, but he's been following up for like 10 years. And this is the Paragon implant, which I think lasted quite a bit longer, if I remember correctly. So you can suture it and do a prosthesis later, and I think the Paragon implant lasted quite a bit longer. So this is how it ended up like this. So this is what it looks like. I'm sorry this is a little bit of a bad slide. It's an analog panorama, no more digital. That's why I spread it out this much. I can't do it now. I just plant it deeper down, which is a little harder to do now. And then I used to use block bone a lot, personally. Carl Misch used to like block bone, and I used to like block bone a lot. But then I realized that the implant is more important, regardless of whether or not you use bone. I still follow up with this patient. He's been with me for almost 25 years now, and I've been following up with him for a long time. So here we are. There's no bone. It's troubling, actually. So now incision, I think I was trying to be good at something back then. So I'm doing incision design, and nowadays I'm doing it a little bit simpler, tuberosity side. I had a chisel at the time, and I would use it to take the bone off, and it would fall out. So now I drill a hole, and then I put billcock bone like this, and then I put an implant next to it, and then I suture it, and then I do a block bone graft like this, and then I do immediate loading. I did a lot of them, immediate loading. Even now, if I have no choice, I do immediate loading. But there's a condition for immediate loading. You have to have a good implant. It's hard to do implants that don't have good initial fixation. So there are certain conditions, like you have to have a good implant design, a wide fixture, and a long fixture hanging, and so on. So sometimes we do immediate loading if those conditions are met. And then you wait about 3 months, and then you open it up again, and it's like this, and then you unscrew it, and then you drill it, and then you do it again. So I ended up waiting another 3 months, and then taking an impression. That's pretty much how we do it all the time. And then we do tooth preparation, so we do a full mouth rehabilitation. And then I used a lot of Gothic arch tracing, because if you don't have full mouth rehabilitation, you're really limited in your treatment. So I would trace the Gothic arch, mount the model, and trace it like this, and it would come out clean. Protrusion, laterotrusion, it all comes out fine. So the TMJ is fine. So I'll take the bite registration out of the mouth, and then I'll do the model mounting, and then I make the prosthesis. Anyway, I worked hard, and that's what appeals to the patient, And that's why they still follow up to this day. They don't really have anywhere else to go because the cases get bigger. And from the patient's point of view, they're going to go to the same place they were before. They're not going to go anywhere else. I don't know why, but I liked metal occlusion, and I like it now. If the patient doesn't have any aesthetic issues, I'll just do metal. I'll do gold, or I'll do metal a lot. I mean, my practice is in an industrial area, so I don't know if that's why. But there are quite a few people who do metal when I say metal. Because sometimes the bite doesn't come out high, and then the longevity is the best with metal. I actually like metal much better than gold. I've been doing it for a long time. And again, this is actually a titanium prosthesis. We used to cast titanium back in the day, and I think that's why I liked it, because it was lightweight. So I used to favor gold occlusion or metal occlusion a lot like this. And then the guidance is fine, it doesn't matter. And then you take a picture in the mouth, and it's like this. Blue is eccentric contact. Red is centric contact. You know, natural teeth have a lot of these wear surfaces. So now I need to create a wear surface on the occlusion, and I've given it a groove and made it multiple points. The original tooth was worn, right? But if you reflect the wear surface as it is, it will be overloaded. So I think I made it by reducing the occlusal area, but forming a groove or fissure with multiple points. And that's how it ended up. So I think that's why it was okay. The panorama x-rays weren't very good at that time. So I took a lot of 10 standard x-rays, and I did a lot of follow-ups and stuff. So I don't know. But now you have quite a bit of periodontitis, right? And you're almost all implants now. And I'm kind of sad to say a lot of the BioHorizon implants here have fallen out. It's terrible. So we replaced them all with SLOCK implants. Anyway, this is what happened, and this is what I did, and I'll tell you about the mandibular nerve repositioning, which I don't want to do now. It was kind of horrible. But at the time, I thought that was the protocol. Like this. The patient came in with one planted somewhere. So he asked me if I couldn't do an implant. And if you look at the pictures, it's all gone. So I said, no problem. I'm going to do a mandibular nerve repositioning, and you're probably going to lose sensation. And I said, if that's okay with you, I can do it. And this was a younger woman. So she said she didn't want to do a partial denture, so I agreed to do it. And now it's simple. You can see the mental foramen after the incision and the retraction. Cut out the back here, like this. And the nerve bundle behind the mental foramen like this. Inferior mandibular nerve, artery, this is the bundle that contains all of that. And now we're going to do a retraction with silk. And then I can see it now. So I can avoid it and place the implant. So I've done quite a few of these, this one too, and then I get almost 100% nerve injury. So there's a feeling that you shouldn't do this. I don't think anybody's doing this now. But there are a few people now, patients like that. So I'm like, should I do it or shouldn't I do it? There are some people who have implants because I told the patient that nerve injury will come even if I don't do it, so I just put it in. I think I used a stereos implant here then. I took out the one behind the long one and put in the long one, and this guy was followed up for like 20 years. I don't know what's going on now, but she lived far away. So I was doing follow-ups, and then at some point she stopped coming in. I don't know, I think something happened. This is a stereos implant, and I think this was a good one. It's got a stronger abutment connection. So I think it lasted a little bit longer. So this is the final prosthesis now. You know, we talk a lot about the attached gingiva. The muscle is attached here. What I mean by that is, if you do a bone graft, it's all gone. So now you can't have attached gingiva where there's a muscle attached. So most of the time, they'll just put something on there to create an attached gingiva zone. You're doing CT grafts, you're doing this, and you're failing almost all of them, I think. No? It can leave scar tissue. But other than that, no. And the attached gingiva zone, where is it attached? It's attached to the alveolar bone. So the tooth falls out, and the alveolar bone is lost. So if you actually look at it, there's no attached gingiva zone. You know, periodontists keep talking about that. They keep telling me in some kind of nuance that if I don't do it, I'm not qualified to do it. So I get gaslighted, and I do something about it. But now it's the most painful surgery, actually. It's the surgery with the highest failure rate. So I can't afford it, to be honest with you. I can't do it either. I'm an oral surgeon by training. I can't handle it, even though I'm an oral surgeon. But I don't know why they do it. I'm supposed to have this. It's nice to have. You can't make something like this that doesn't exist. I said, try to make a case like this. They can't make it, never. But it's been there for over 20 years. It's kind of comfortable to have. But this shouldn't be the case. Common sense dictates. So it's like, do a research. So now I can suture it like this. And the guidance is kind of like canine guidance or something. Anyway, this is how it ended up. And this is the final x-ray. And I think it was kept for quite a while. So the follow-up was quite long. So I think this was about 10 years old. I think this was taken at that time. And there's no bone loss. I think the most important thing was to use a long one and to have a solid abutment connection. Even now, if you ask me to do an implant that lasts this long, it's all about size, then good location, good orientation, and then a solid abutment connection. As far as I know, implants will definitely last long if these conditions are met well. So now we've talked about getting and maintaining osseointegration, and then I think we're probably done for today. But I mean, in the long run, implant therapy is success or failure. Some people talk about the success rate, 99.9%, 99.7%. I've heard a lot of stories that are kind of ridiculous. It's almost like, you know, some people give lectures like this. If you listen to the famous people, there's two kinds of people. There's one category of people who talk about their success rate being so low that it's embarrassing. And there's one category of people who talk about how they never fail. I don't know which one is right, from my personal perspective. But if you do a long-term study in the brain mark implant group, 10-year follow-up, the success rate in the maxilla is between 80% and 90%, and the mandible is in the low 90s in the brain mark implant group. But the weird thing is, Korean people, Korean domestic implants, they count like 99.7% of the time. So I don't know which one of these is true. They have no shame or something. The people who are in universities, the people who study a lot, the people who do a lot of research, they're honest. They say the long-term success rate of the implant is around 90%, and the initial success rate is around 96%. And then there are the famous implant companies, like ITI or Nobel Biocare or 3i or whatever. And most of these companies don't tell you that their implant success rate is over 96%. But there are some implants that are a little bit questionable. The ones that don't have a lot of self-respect, they'll say 99.9% success rate. Even our SLOCK implants, even with the nano SLA surface, there are quite a few cases where the patient's bone is actually bad. So I don't know about the long-term results. I was going to say 97%, 98% success rate in the long term. But when I hear the success rates of other major companies, it's almost like, am I saying this wrong? For some reason, it's become a trend to talk about excessive success rates. If you're talking about excessive success rates, you don't have to worry about placing an implant. If you just use those implants, you're going to have a 99%, almost 100% success rate. So you can just put implants in willy-nilly? Well, you said it works in all cases. I don't think it sounds that weird. But it's a little hard for me to understand, because most people say that. So I think that if you think about your successes and failures, you'll know more about yourself, right? You say it always sticks. The implant brand that you used before that, they say it's almost 100%. Does that make sense? It doesn't make sense. But of course they say it's always going to work. And if it falls out, how do they tell you? You're out because you're not good enough. It's like swearing. It doesn't make sense. So now it's more of an overall, if you think about success and failure, things will become clearer. So actually osseointegration is bone ankylosis. But there's actually a phrase that says that's wrong, because osseointegration says that bone is attached. And if you think about it, metal and bone are different. There's no concept of dissimilar materials sticking together. There has to be an adhesive in between. If you study implants a lot, you talk about glue a lot. They say, I wish there was an adhesive for implants that sticks to bone. So one of the things that I was thinking about a lot at one point was trying to put a lot of bioactive matrix on the surface of the implant. And that's ultimately bone factors. Bone morphogenetic factors, BMPs, to try to build bone. But again, the bone and the implant don't bond. It's intimate contact. Is that Pascal's principle of surface tension? If you look at it, you can't take it off because you put water between the glass plates. But it's actually not really stuck. It's an intimate contact. So the surface is completely pressed together, and it takes a vacuum force to pull it off. Right? So it's the same thing with implants. How can titanium be attached to bone? It can't. So if the bone is very close to the surface of the titanium, so that there's no gap, it won't fall off. What is the titanium surface of the implant fixture? It's got screws, threads, and bone. If it's SLA, it's going to have micropores. So if you sand it, you're going to have some micron scale irregularities. Of course, the macro level is eventually the threads, and then if you sand an SLA, you get the micro level. And then you have a nanostructure, like our SLOCK implant, which is a nanostructure, and then you have irregularities in the nanoscale, and then you have the bone growing in close proximity, so when you have intimate contact, it doesn't fall out on its own. That's how I would describe it, but if you think that osseointegration is going to attach something at the molecular level, you're really wrong. You can't think of it that way. So it's really less about the bone ankylosis concept and more about the intimate contact. And the situation where the intimate contact is slipping and falling off, like this is a loading condition problem. If the force on the implant is not up to that, the implant stays in. That's the accepted wisdom. That's the current understanding. Even more recently, some people have measured the turnover rate of the bone around the implant. What I'm talking about is, if you take tetracycline periodically, it causes bone labeling. They measure that. What he's talking about is that the bone around the implant is maintained by periodic regeneration. You're talking about old bone being lost and new bone being made. So if that cycle is too fast, the bone is now a pathologic fracture. So some people have measured that. So if you think about it, We think of ankylosis or osseointegration as the bone staying together. But if you think about bone from a physiological perspective, you're resorbing old bone and you're growing new bone, and you're constantly replacing it. So just thinking about that, bone ankylosis doesn't make sense. How does that make sense? Bone ankylosis doesn't make sense. So how the story ends up is that we're proving bone remodeling in terms of loading conditions, because there's a process where the bone has a turnover rate and it's constantly being replaced. So I would recommend using the largest and longest implant possible. So macro, threading, micro, sanding, or acid treatment, creating a nanosurface of these structures so that the intimate contact can withstand the loading conditions. Those implants last longer, and those that don't, they don't last as long. Some of the fixture threads are very sharp. This is even worse. And the reason for that is because to keep these threads sharp, most of them use grade 5 titanium. So they use grade 4 or 5. And I think Nobel Biocare or something like that uses grade 3. In the early days, it was grade 1. It went to grade 2. Then it went to 3. And now 4 is pure titanium now. And grade 5 is ELI, so it's a titanium alloy. So now if you want to make a very sharp fixture thread, you have no choice but to use grade 5. Otherwise, it just breaks and bends. And then grade 5 has 10% heavy metals in it. You've got aluminum and beryllium. Is it vanadium? Anyway, it's got those heavy metals in it, so it doesn't actually stick very well. So it's bad for the cells. It's toxic. What I mean by that is that as the bones continue to regenerate now, they're somehow affected by the titanium, the material. So at the end of the day, I know that the initial success rate for implants made with grade 5 is in the low 90s. There are people who claim higher. They're talking about 91%, 92%. I'd say grade 4 is a little bit 96%, 97%. Now, depending on the company, they're going up to 98%. So that's what I know. Eventually, if you don't have good loading conditions, you're going to have a little bit of a disruption in the regeneration of the bone, and then they're just kind of melting away. So what I mean by aesthetic is that the bone is being maintained. So now we have a weird sound because we focus so much on periodontics. Because if you have an attached gingiva zone, think about it. It's aesthetic. What do you need to have an attached gingiva zone? You need bone. So then there's 3 things that we talk about a lot. White aesthetic, then red aesthetic, then pink aesthetic. White means that this dental prosthesis needs to be very aesthetic. You can't tell which one is a tooth and which one is an implant. And the pink aesthetic is talking a lot about this periodontium, and the yellow aesthetic is talking a lot about bone. So at the end of the day, if you work backwards, if you don't have a yellow aesthetic, you don't have a pink aesthetic. It can't exist. But they're saying the opposite. If you do an attached gingival graft, if you do a connective tissue graft, you make it sound like the bone is preserved. But what happens if you do a graft where there's no bone? It creates a periodontal pocket. So you're doing surgery to get rid of a periodontal pocket, and you're doing surgery to create a pocket. And I'm not sure how that works. I don't know by what logic these 2 things are possible, but the natural tooth is trying very hard to eliminate the pocket, and the implant is trying to create a pocket. I'm not sure what the heck this is all about, so it's kind of frustrating for me. Anyway, these aesthetic issues are also dependent on how much bone is retained. So the aesthetics are retained, right? You can see the interdental, interimplantal bone is well shaped. So how do we create these things is important to us. And first of all, you have to place the implant in a good position and in a good orientation. And then you have to make a good prosthesis. And then you have to have a good abutment connection. And then you have to have a strong abutment connection. There's no way around it. And this is a lateral incisor. Same thing here. It's aesthetic. It's got a good emergency profile. It's got a good implant. It's planted like this. I had a block bone defect, so I did a block bone graft, and then I placed the fixture in a good position, in a good orientation. The prosthesis is clean, but any abutment connection that has micromobility will melt right down to the first thread. So that's why I usually use SLOCK implants with Torx++ or locking taper abutment connections. I mean, if you can preserve the bone around the implant, it's aesthetic. And it's all about aesthetics, and it's all about placing the fixture in a good location and in a good orientation. We say a lot of things, but at the end of the day, we say form follows function. Literally, form follows function. Aesthetic eventually follows function. So it's a functional aesthetic. It's just aesthetic. It's aesthetic because we did periosurgery and made a gingiva. Then the prosthesis is aesthetic because it's a nice color. It's a little bit of a stretch to claim that. So if possible, you want to put the fixture in a good place, in a good orientation, and make it functional. He's still treating. 12 prostheses with 6 teeth in the maxilla. This is a brain mark. This is a brain mark implant. And this is a 29-year-old, almost 30-year-old implant. I think it was a gold abutment. It's so old that this is the gold. This one hasn't come loose. And I heard a lecture once upon a time. I think there was a professor named Ramfjord. I took a periodontal lecture, and he's a prosthodontist at the same university, and he said he did this, so I did it. And it lasted 30 years. I think it lasted 29 years. I had quite a few cases where I did this. But at that time, implants were very expensive, so I did this, and I was a rookie, and I planted it wrong. This is what I pickaxed. This is what happens when you move your wrist like this. When you're planting, you're supposed to plant with arm movement like this, but if you plant with wrist movement, it becomes a pickaxe. What was it then? 3.75 millimeters in diameter, and I planted the longest one I could. That one lasted a long time. Because of this. It's not pretty, because it's a little bit in a bad position and orientation, but this one lasted quite a while. This is the follow-up until recently. If you look at the picture here, this is what we used to do. I did it like this, just put it up, drill it hygienically, and then have them use an interdental toothbrush, and then do a gold occlusion. Anyway, I've had them for like 25 or 30 years now, and the patient loves them. I'll show you another case next time because this side is coming out, and I'm putting an implant in, and the other side is coming out. I did it like this. So, actually, I was in China recently, and what the Chinese dentists were telling me is that implants don't last very long. I guess China is going crazy right now. Well, actually, the Astra connection, for example, old abutment connection, it's pretty much adopted by our domestic implant companies now. It starts to loosen after about 5 years. I think it's my understanding that after 10 years, 10% of them come loose or break. I think that's something that most of us agree on. I think it's worse in China because you don't plant in such a good location, in such a good direction. So it's more serious. And what you're saying to me now is that if you have a solid prosthetic protocol, you're probably going to have more success. And it's really simple. You've got to put the implant in a good location in a good orientation. And then you want it to be as big and thick as possible. And then you want to have a strong abutment connection. But one connection has historically failed. There's no country like Korea that's unified with one connection. So the major companies have 3 different abutment connections. They even have 4. We probably have 5 different abutment connections. So we've been trying very hard to reduce the number of abutment connections because we're running out of product stock, and so do the doctors. But from an aesthetic and functional standpoint, I feel like I shouldn't be reducing the number of abutment connections. This patient is also quite old. I don't know if he's still alive. I still remember when this patient first came in, I was charging him X million won apiece for the implants. He didn't look very wealthy when he came in for his consultation. So I asked him, and he said he had bad teeth, so he saved up. That's how he came in, and I think he probably died. I can't not follow up, because these are expensive treatments. He had an iliac bone graft, and he had a maxillary implant. He did an iliac bone graft for the maxilla, and this is an older case. Most failures happen in a week to a month anyway. If it's occlusal overload, you're out. If it's more than a month, then it's 5 years, 10 years, you're right. But now you've got another year of osseointegration. You need to tell your patients to be careful. That's a lot of people. We started with squid, and then we had stir-fried black beans. What do we call Korean people? Korean people. I think it's the country of bruxism. It's a lot of people. So you have to be careful. They say that this functional loading can go from a month to a year, and the osseointegration continues to increase. And when it gets pathologically bad, that's when you move on to this. So the biggest problem is crestal bone loss. And then peri-implantitis is kind of a problem, and that's why it fails. So if you look at this, it's serious. This guy was very expensive. I mean, it was early days, million won a piece. So how much did he get paid? I was paid a lot. And he comes in like this, and he's like this. And he has no complaints. He eats 1 squid a day without fail. Then there's the black beans, which I mentioned earlier, and he eats them stir-fried all the time. He's tall and healthy. Recently, his son was treated, his wife was treated, and he brought his wife with him. Anyway, it's serious. So he just asked me to do it again. So I put it in and took it out. It's worse here, actually. If you look here, it's almost like you can't do it, right? It's almost like that here. But we're not worried, because the patient is healthy. So we put the implant in, and we're hoping for natural bone healing. There are so many cases like this. There are a lot of cases like this, not only in Korea, but also in China, where a lot of bone is missing. I'm not worried about it. Because if you look here, there's a line from here to here. From here to here, there's always bone. It's the same here. You'll always have bones where you connect them. Just wait. Along the way, another osseointegration broke and fell out. It was a grade 5, so it didn't stick then, not now. So I planted them all. It's beyond common sense. Now they're talking about grafting it, but they don't bone graft. If you do, it's a bigger problem. You don't have to bone graft, you don't have to wait. And then if you wait, the bone just fills up more. It just comes up more. So you prosthesize it, and then you do the same thing on the other side. Same thing, you wait, you put it in, you wait, it fills up again. You look at it, and it's full. Right? And then I plant another fixture, and then I plant it like this, and then I wait, and then it fills up again. So it's a cycle. So now a lot of people ask me, they're like, how did the bone come up? Did you do anything special to the implant? And it's not like that. It's just supposed to come up, normally, as long as I don't get in the way. If you have a partial denture here, things get more difficult. You've got this locking taper here. You've got a screw-type implant here, and you've got micromobility. It's not going to come up, no way. There's no mobility in the abutment connection structure. So this is what's holding it up. So you've got success, survival, so things that didn't function, and then failing, failed case. What do we call this? This is failed, this is failing, this is failing. Well, it's just a matter of time. You see a lot of these cases, and then you talk to the patient. The implant is failing. If you continue to have inflammation, you're going to have to take it out and do another implant. The patient gets really upset. And I'm like, don't worry, we're going to do it again. And I'm like, well, we did this before, and it's not working out. You've been doing it for about a decade. This guy came to me in 2002. He is patient number 5 in our current dental practice. I moved the hospital over here in 2002 when we had the World Cup in Korea. So now I've had it for over a decade, so the patients don't complain. But if this second one fails, I'm going to be an idiot. He's very upset because he's building it, and he's got plenty of money, so it wasn't a matter of money for him. It was a matter of whether or not I could get this done in the back. So we took out the rest of the problematic implants and redid them, and now he's fine. I actually have a lot of patients like this, not only in Korea but in China. It's unbelievable. There are so many. I have patients who come to me because their bone has melted down because of peri-implantitis, and I treat everything with natural bone healing. I have a lot of cases like that. So we can't all succeed in the end. You're going to fail, and in the process of failing, you're going to have to think about how you're going to deal with occlusion and stuff like that. So you have to distinguish between surgical failure and occlusal failure. What is this? You've got a prosthesis in. It's been over a month, right? Think about it. That's not a surgical failure. It's all occlusal failure. You can't go wrong with surgery, if you think about it. But most of the time, what they say is that the surgery went wrong. It's been over a month since the prosthesis is in. How can that be a botched surgery? What's wrong is this. If it's in the wrong position, if it's in the wrong orientation, if it's a custom abutment, if it's forced to be oriented, then it's the surgeon's fault. But if the fixture is in a good position, in a good orientation, then it's not the surgeon's fault. Even if it's over 10 years old. If it falls out, the failure is on the occlusal side, not the surgical side. And it's actually a failure of the implant design in this case. This is a biohorizon, so it's made by Carl Misch. No, I'm sorry. In Korea, it's called biohorizon, but in the US, it's called Maestro. This implant was really bad, because this is a grade 5. It's grade 5, threaded, and there's very little space between the screw bones. And it's a deep threaded bone. I told you. What happens to these things? These threads are pointy. If you press it, the bone will never hold. It's not going to hold. So all of these implants have failed. Initially, they came out with TPS, titanium plasma sprayed surface. TPS, when it starts to fall out, the infection is huge. The SLA is huge. You see the infection? It's horrible. It's pus, it's swelling, it's smelly, you can't afford it. So this case is an implant design failure. So it's not a surgical failure. It's a failure of the implant itself, and then it's a failure of the occlusion. So that's the distinction that needs to be made. And how we talk about it a lot lately, crestal bone loss is bone from the top down. So if the bone on the crestal side starts to melt, it will eventually continue to ride down the surface of the implant fixture. So that's what's being reported a lot right now. So actually abutment connection issues, design issues, are playing a role in implant success and failure. And we're focusing on abutment connection design and fixture design because it's the most important part of maintaining the crestal bone level. So at the end of the day, if you really think about it, it's not a material problem. Grade 5 is still bad, but most companies are using grade 4 or 3. And think about it. The only countries that have companies that produce titanium are the United States, Germany, and China. I guess you have to have a furnace to remelt the titanium. I use very little from China. It's almost all from Carpenter in Fitchburg, USA, and titanium from Zap in Germany. So it doesn't make sense. I mean, material is the same. Surfacing is either SLA or HA. What's the next thing you can do? The abutment connection design and the macro design. And I think that's the most important thing that determines the characteristics and the outcome of the implant. So I think we're almost all focusing on macro design these days. So I think you're right about using an implant design that can prevent peri-implantitis. If it melts like this, there's nothing we can do. I feel bad for him too. She was a teacher. You know the Sewol Ferry? She was one of the teachers that was killed, and there were probably like 6 people whose bodies were never found. I think it was 5 or 6, and you were one of them. He is a great guy, also has a great personality. He just melted away like that, and we couldn't do anything about it. It's sad. You see, it's all melted. Some religious organization planted the wrong implant. There are people who have implants while leaving religion, and they can't even express their complaints and come to me. I remember taking it all out and doing a new one. If you look at this picture, it's broken. The implant was too weak. I can't even speak. It's like this. It's coming. It's broken. It's gone. And this one's still here. And this one's all broken. And then the rest of his teeth were rotting away. And then he came in with a screw that came loose, which I think is a 3-eye implant. He's from out of town. And I don't even remember how many times he tightened it. I don't know if he finally gave up on me or not. One time, there's this place, we call it our school. He got in trouble with the law, and I think he did some jail time. And when he came out, he was just pissed off. And he was like, the screws are loose. And I couldn't handle it. So you get this occlusal overload, and then you end up with fibrous integration, and then you get a secondary infection, and then you get another bone destruction because of that secondary infection. And it's a vicious cycle, and the implant fails, and that's what we know, and that's what we're talking about. So we need to break this vicious cycle. And then there are times when it happens. The abutment screw came loose. What happens to the bone? It dissolves. Same thing with this. It's all melted. The abutment screw is loose. This is a brain mark implant. It's all melted. Bone. Fibrous integration. We see a lot of cases like this, right? Crestal bone loss. We see so many of these. I remember this one. This is a patient of mine. What happened to this one is I put a thick implant fixture in too thin bone. It's a knife edge, and I put a thick one in. I got greedy. That's what happened. And then this is my patient now. I put in 10, and 9 fell out. It's frustrating. It's a biohorizon implant. This is a failure of implant design, in my opinion. And then you look at all these other cases, and I planted it, it fell out again, and I planted it again. I think it's because of number 7, number 8. So I said, let's take out number 8 and re-implant it. And I did it for free. So that's how I've been using it for almost 15 years now. He's an employee of this town hall, so I know him very well. I took out number 8 antagonist teeth. It was occlusal, eventually. So this went on for a long time. And then he don't say anything. And then I kept following up. Eventually I had to think about a second molar single implant and then a third molar single implant. If the occlusal surface is bumpy, it doesn't last long. And then if there was mobility in the adjacent teeth, it didn't last very long. So I think at the end of the day, if you think about the successes and the failures, you can understand what you can do to make your own implants more successful. You place the implant in a good location, in a good orientation. Then you have a good occlusal protocol. Then you have a solid abutment connection, a connection that doesn't have micromobility. Macro design is important. And then the surface, a clean surface anyway. And then maybe SLA or SLA nanosurface is a little bit of an advantage. I think it's this concept. Other than that, there's nothing special actually. And there's nothing special about it. We don't do bone grafts where possible, but we induce natural bone healing. I think that's what's so special about it and nothing else. And I think that's how I've been able to increase the success rate of my implants. And I think that's why patients keep coming back. They like it. And then we have a good relationship. I did a lot of implants today. I also did a lot yesterday. And we're still getting more and more patients. I think we had a slowdown at the end of last year because the economy is not good right now. It was very extreme before and after Chuseok, and I think we've been doing well since then. I think I have to do a better job in the future because I keep getting more patients. That's how I realized these things, because I studied myself and did implants for a long time. So I wanted to pass along that realization. That's all for today. Thank you very much.